So congratulations to those who already have nursing home contracts. And to those of you who don't have any, don't be discouraged. Hopefully, after you complete this webinar, you'll have the additional tools and information that you need to make contact, secure those contracts, and then get your programs up and running. So the topic of this webinar, navigating the CNA clinical during the COVID-19 crisis, and that is me down there. As Victoria said, I am a licensed nursing home administrator in the state of Louisiana. So I'm going to give you some insight based on what an administrator would look to see when, I guess, going on to sign a contract for clinical.
Is it
So some of
allowing
the
you?
objectives.
I'm sorry to jump in. Is it allowing you now? I thought I did.
Let me see. No, not yet.
I don't know what I'm doing.
It's fine. I probably look a mess, y'all. They want to see the PowerPoint anyway.
No problem.
It's fine. So the objectives are, we're going to identify some of the common misconceptions and the barriers to securing clinical training sites. We'll identify some of those resources and statewide nursing home initiatives on COVID-19 management. We'll identify the appropriate transmission-based precautions for COVID-19 so that you can slide that into your infection prevention and control curriculum. So we'll go through things like what's the appropriate versus the acceptable PPE, familiarizing yourselves with the universal source control protocol, making sure that you're stressing hand washing to your students, and then understanding how to incorporate those facility measures that they're using to mitigate the spread of COVID-19, how you can implement that or incorporate those into your school trainings so that it's reinforced prior to starting clinical training. So some of the common misconceptions and barriers to obtaining a clinical contract. So facilities have policies and procedures in place to accommodate and provide guidance for academic training. That is a huge misconception. Most facilities do not have specific policies and procedures in place to give guidance for academic training, let alone academic training during a pandemic. So it's so important for you as a school owner and as a nurse aid instructor to make sure that your infection prevention and control curriculum, as well as your policies on how to manage COVID-19, provide the structure that your students will need to operate in the clinical setting. Nursing directors are experienced in developing appropriate clinical assignments based on acuity. This is also false. Many facilities, especially larger ones, have a staffing coordinator that may not be clinical. And staffing coordinators are trained to staff the facility based on acuity and to accommodate what's called the PPD, which is the patient per day. Basically meaning whatever our census is in acuity, there's a specific number that your state requires them to have a ratio for this many staff per day to take care of them. So when we set up clinical training, a lot of the times we like to go and sit with the director of nursing to discuss how the patient assignments will go. And a lot of times we don't get the straightforward answers that we need as far as pairing our students based on the skills that they've mastered in the classroom setting, pairing them correctly based on acuity in the facility. So one thing I suggest there is making sure that you make contact with who actually does staffing in the facility so that you can review with them where your students are as far as the skills competency and use your skills checklist as a point of reference and make sure that whatever area you're assigned to in the facility, it matches what your students are comfortable taking care of. The next one would be the school's curriculum does not need to include relevant content on long-term care. This is also false. So as you all have worked with Victoria or any of the other program consultants, as you know, when we do the initial licensure, we send off your curriculum. However, your curriculum does need to evolve rather. So as the pandemic has shown us, we do need to update infection prevention and control practices and add a specific piece on COVID-19 management so that when your students get to clinical, it's not all the question marks because they don't know how to properly don and doff PPE and they don't know the difference between contact and droplet precautions, and that COVID actually requires both. So you do need to make sure that your clinical curriculum, or your classroom curriculum rather, is actually relevant to what's going on right now. That may require you to send updates and get additional approval from the state. But again, you are trying to train tomorrow's healthcare workforce. So if this is a necessary step to make sure that your school stays ahead of the game as far as making sure your students are ready to work, this is something I would definitely recommend incorporating.
And that's a good point, because a lot of people actually forget that when you make updates to your curriculum, you have to send that into the state to get it approved.
Indeed, you do. You definitely do. The last one would be instructors who have extensive nursing experience do not need to be knowledgeable on long-term care regulations and documentation requirements for nurse aides. This is a huge, huge misconception. I've seen nurses who have worked critical care, who've worked in the academic setting on a collegiate or graduate level for years. However, when they come to nursing homes for clinical, their students do poorly, and it's just because they're not familiar with the regulations of long-term care, so they are not incorporating that into their curriculum. So you definitely need to make sure that you are knowledgeable of what is cutting edge in long-term care, so that again, you can incorporate that into your clinical training so that your students are prepared. One interesting fact that I learned when I was doing my nursing home administrators training, or AIT training as they call it, is that nursing homes are the second heavily rated as far as the regulations, the first being nuclear plants. So we can only imagine how many regulations and how many regulatory bodies that a nuclear plant would be responsible to and have to be compliant with. So nursing homes would rank number 2 right under them. So you definitely want to make sure that you are familiar with the terminology in long-term care, so that again, your students are not shying away from these opportunities in clinical, but they actually do well. So these are some strategies to kind of overcome those barriers. First, you want to familiarize yourself with the positivity rate. Every state that has counties, or where I live, we have parishes. Each week, the health department rolls out a positivity rate. This positivity rate is divided based on county. Wherever your nursing home is located, the one that you have a contract with, or one that you're interested in obtaining a contract with, keep up with their positivity rate. Because most times when the positivity rate gets over the threshold that's defined by the state, and in my state of Louisiana, it's 5%. Once we go over the 5%, we go on restricted visitation again, and then it also does require the nursing home to increase the testing of the residents and the staff. It goes from once a week to 2 and 3 times a week based on that county positivity rate. So some of the resistance that you may be getting to securing the contract is because that county positivity rate is above the threshold. So you can definitely check with that facility to see if they're having issues, if there has been a recent outbreak. Of course, due to HIP, it's only so much information they will give you, but sometimes you kind of need to know when it's a null point. And if that facility is really struggling with outbreaks, you may want to find another facility that has a little calmer or more control over their COVID-19 mitigation strategies. If you do find a facility that is willing to allow you to host, you can also request to be assigned to a non-COVID unit if that is possible, or you can suggest minimizing your clinical groups to minimize that additional visitation in the building.
So when you say minimize, do you mean like rather than bringing your whole class of 10 people, see if you can bring 5 at a time, or what are your thoughts?
You may need to, just because if that positivity rate, I know specifically in Louisiana, if we're over 5%, it's only so many visitors we can have in the building that week. So they're going to start off with the essential visitors, which would be your providers, and then your lab company. If you have x-ray or ultrasound technicians that need to come in, they would all be considered essential. Like your food vendors, it's a certain point they can come in the building. Those people would be considered essential. And then they would accommodate the residents' family members. So then trickle down the line would be students. So if one way to get around that is decreasing that clinical size, they may be more willing to allow you to bring 5 students in so that it doesn't cause them any issues with bringing in essential visitors. That may be something that you want to consider if it's possible.
That's a good negotiation strategy. And that's some great insight on the back end. I didn't know about that. Okay.
So another thing to consider would be PPE. A lot of facilities are still having issues with securing adequate amounts of it. Many of the larger vendors, McKesson and Medline in particular, have done allocations for larger hospital systems and larger nursing home groups. So for the entire month of March, you may get these many gowns, these many N95s, these many surgical masks, and these many pairs of gloves. And so you have to make it stretch. So if a nursing home is going to choose between having adequate PPE for their staff and their providers or accommodating students, they may be a little reluctant to open the doors to students for clinical training, especially if it's students who we don't know if they're really comfortable with donning and doffing properly. There's a potential for waste. So one way to get around that is to try to supply your own PPE. And I know that seems like a stretch, but again, we're in a pandemic and it's already not enough going around for the essential personnel. So having a plan in place to try to start securing PPE, even in limited quantities for your students, may be a bargaining tool for you to use to get that clinical contract. You can also ask for a specific area within the facility so that the students can keep their PPE on site. So at the end of the clinical shift, they can decontaminate it. They can store it in something as simple as a Ziploc bag. I've recommended schools that were coming in when I was an administrator, we bought over-the-door shoe hangers from Amazon that had maybe 12 slots in them. And so at the end of the shift, they would decontaminate it with the appropriate disinfectants. They would seal it in a plastic bag with their name on it and put it in the over-the-door shoe organizer, and then it would be there for them on the next shift. So that was one way to keep their PPE separate from that of the staff, but then it also helped to reduce waste with the students using constantly. Make sure that you have policies on COVID-19 management for your school. And within those policies, you need to have something in writing regarding student testing. Some facilities may require proof that a student has tested negative within so many days of actually starting clinical. Additionally, based on your county's positivity rate, however many times a week that the nursing home is required to test their staff and their residents, it may be a good rule of thumb to suggest that your students are also tested along with the staff at the facility. There are provisions in place in certain states, whereas if a person doesn't have insurance, the state picks up the bill for that testing. So if they are doing clinical training, they should be able to test with the staff there on site and then have those results there so that they're still getting tested while they're in clinical. But then it's no concern about if once they get out of clinical, will they really go get tested and will they really return the results back to the school to make sure that they are still negative. So one way around that is to suggest, if possible, them being tested alongside of the staff at the facility. The last piece would be to require the students to complete a triage screening form to make sure that they're checking for any symptoms and especially to check to see if they have any temps prior to building entry. Make sure that you are speaking to any potential HIPAA violations and make sure that you include that in your negotiations for clinical contracts, that you have discussed with the students that they are not to disclose anything regarding positive cases, suspected cases, or unknown cases to residents, caregivers, visitors, any news media. I noticed in Louisiana in particular, because we had such a hard time back in March and April of last year, the news media would camp out in the parking lot and try to find the most least suspecting person to get information from. So make sure that your students are aware that anything related to COVID, confirming cases or confirming if it is an issue within the facility, make sure that they understand that any communication regarding who is positive or who was exposed should come from the facility and that they're not to disclose that to anybody. And make sure that the nursing home understands that you are incorporating that into your curriculum because again, that's another bargaining tool to show that you are really ready to have clinical training under these conditions.
Wow, they'd do anything to get some information, won't they?
They were camped out on the side of my car. Wow. Trying to find, and it was a brand new CNA, but that was a part of her orientation. So she, quickly responded appropriately that the facility had protocols in place and that they were not to speak of anything. But those are the things that they do to try to get inside information. Mm. So just good things to make sure that you're speaking to those things because it just makes the nursing home feel a little more comfortable that you're aware and you have plans in place to, to address these issues. Another big one is the COVID health surveys. As many of you know, nursing homes are surveyed at least annually. And then whenever there's a complaint, they can also have a survey. The pandemic really disrupted the frequency of surveys. And then with the severity of the pandemic in the long-term care community, there was a special survey that was rolled out, which is the infection control or the COVID health survey. I've had, when I was working as a long-term care administrator, as many as 3 surveys in a month. At that time, my COVID rate was 0. I was testing weekly. I was reporting weekly. Everything was compliant, but they do random pop-up surveys to see if your staff are constantly being educated, if your residents are being educated, and if there is that communication with families. So all of that to say, if you are granted clinical privileges, please make sure that your students understand the severity of these health surveys. There is a new tag or an addition to the federal tag, which is F880. F880 is one of the deficiencies that they will cite when they come out on a survey if there's any issues that they find with infection control. CMS has updated F880 to include COVID-specific mitigation. So they will tag a facility based on your students' mishaps. And I know a lot of people believe that, oh, well, they won't tag, it was the student. The student was on the premises. And if it is a breach and something that could possibly cause or trigger another outbreak of COVID-19, the facility will get that tag. The bad thing about F880, especially when it comes to COVID mitigation, most of these require what's called a directed plan of corrections, which requires extensive training and extensive documentation showing that you are re-educating your staff on compliance. And it also comes with civil penalties. So if you have a clinical contract and one of your students calls an F880 tag, I'm gonna just tell you, if you were in my building, you will not be back again. Because the civil penalties are per day until you clear the tag.
Wow.
Not to mention, if I do not give substantial evidence to show that I have re-educated and decreased the occurrence or the potential for this to occur again, I could go on denial of payment, which means that that facility won't get paid on any new admits until they clear their deficiency. So all of this is going on the back of a nursing home administrator's head when somebody calls and say, I want to have a clinical contract. So if you're not saying the right language, and if you're not saying that you have prepared to educate your students and they're aware of what's expected of them in the clinical setting, a lot of that could be why you're getting no's or not even getting responses back at all, because all of this is what they have to consider when they're agreeing to let students come into the building. Some other concerns or some other considerations rather, you may want to also consider including a waiver of liability that your students would sign before starting clinical to protect your school and also protect the facility so that if a student is exposed to COVID-19 while they're in clinical, there are no legal ramifications.
I hope y'all got y'all pens out. This is a lot of information, but it is some good stuff.
I have seen students before try to say, well, when we had to do contact tracing, well, I got it at the nursing home and I'm gonna call my lawyer. Well, it's nothing that your lawyer could do because this administrator also owned the school and had your owner to put something in writing saying that we are not responsible. But you need to make sure that you have that because that protects your school and it also protects the facility. Other things that you may want to consider, and again, this would require approval from your state board, but if you are really getting hard-nosed for clinical training, consider offering training at times that better suit the facility staffing needs. So if 3 to 11 is a shift that they are really struggling on, if that's something that you can get permission from your state to shift your clinicals to 3 to 11, if that's all I need to do to get a yes for clinical, then we're going to 3 to 11. So just those are some things that could be helpful. I'll go through the infection prevention and control. Most of you already are aware of this stuff, but I will just touch on it again because this is some information that you may want to slide into your infection prevention curriculum, or if you don't have all of this in it, you may want to add to it. Make sure your students understand the modes of transmission so that they don't get in clinical and embarrass you and saying that you get it a certain way when it's from close contact, droplets, and then touching an object or a surface that's contaminated. The symptoms, make sure that they are aware of all of those, not only for themselves doing the self-symptom checkers, but also if they notice something while they're in clinical, they do need to report that to the nurse right away so that if that person is not already isolated, they can begin isolation and then whatever the necessary steps are based on that facility protocol. I see a lot of people misconstrue the appropriate transmission-based precautions for COVID-19. It requires two. It requires droplet and contact precautions because of the way it is transmitted. So make sure that you include that in your curriculum. Make sure also that you are getting the updates from the CDC and your state health department. They usually send out, at least, if not on a daily basis, at least weekly, emails regarding whatever the updates are from the CDC and from the WHO. And it also gives you helpful information, especially education. So a lot of times you won't even have to change anything. You can go straight from the information they send you in the email and incorporate that into your instruction. I've trained so many people off of flyers from the Department of Health's website and had them sign off on it that they were compliant and was done, but I didn't have to reinvent the wheel. So that's something that you may want to look to as well. Also, it's important to get those email alerts because if it affects the nursing home, 9 times out of 10, it's going to have some impact on your nursing aid program as well. So from the school email address, or if you don't have that set up yet, even from your personal email address, try to log on to those sites and try to get those weekly or at least daily emails so that you can stay abreast of whatever those changes are.
I know I've been getting them weekly from Indiana and North Carolina. I signed up. I try to sign up for those. So if something's big, I can let you guys know those things as well. But they do come so often that I can't even keep up to date. But
Yeah, it gets to be a little aggravating and it can be overkill at times. But again, if we are trying to determine whether or not it's appropriate to continue clinicals in a certain county versus others, it's good to have that insight. And you're getting it straight from the health department. So you're not worried about third party, if it's true or not, the news, are they, sensationalizing it? You're getting it straight from your health department. So it's pretty much tried and true. Make sure that you, as an instructor or a school owner, understand the difference between an observation and an isolation unit. Observation units are for people with possible exposure or unknown exposure, and they have not necessarily tested positive yet. They usually have a designated unit, and it's usually 2 unknowns or 2 observations. They can be cohorted together. The nursing home should not be mixing, and they won't be mixing a definite positive with an unknown. It should be positives together, unknowns together, and it can be 2 separate units. So make sure that your students understand if they're on an observation unit, these are the people that I don't know if they have COVID or not. We're going to treat them like we have it, but we are not 100% sure. But it's make sure that they understand the difference between the 2 so that they are properly changing out their PPE if they are providing care on both the isolation unit and the observation unit. It's usually dedicated staff. That's in a wonderful world, but it does not always work like that. So as the instructor, especially if you're in the clinical setting with them, make sure that you have identified what's observation versus what's isolation, because again, you don't want it to be where it's your students that are responsible for possibly cross-contaminating or introducing something into an observation unit. Again, if your students are working this area, make sure that you have waivers in place beforehand. Also address all of their concerns prior to starting clinical. I've seen it with my own eyes, heard it with my own ears, students having a huge meltdown in the hallway because I have immunocompromised loved ones and you got me here on a COVID unit, and it's not a good look. So work through all of those issues prior to getting into clinical so that there are no huge blow-ups at the facility that you fought so hard to get clinicals at, and here it is, the students saying they can't work it, they're not working it. So make sure you have all that taken care of beforehand. This is straight from the CDC website. Appropriate versus acceptable PPE. So if you're going to provide PPE for your students, appropriate would be the N95 or the KN95 and the face shield. Acceptable would be a surgical mask and the face shield. Make sure that you go through the order of donning and doffing with them, because I have sent schools home before that they were just contaminating everything, taking off stuff in the hallway, and it was just too much of a risk. So make sure that you have all of this information. Everything is pulled straight from the CDC. And if you go to cdc.gov/coronavirus, you can pull up everything that you need to know as far as appropriate versus acceptable, and then the order of taking on and putting it off. Make sure you are familiar with the term universal source control. I had a school owner call and they wanted to have clinical. And so I said, okay, well, how do you feel about, this was before masks were actually required, but my facility was adhering to universal source control. And I asked, what were her thoughts on that? She had no idea what I was talking about. So make sure you are familiar with this. This is the CDC's recommendations for the best practices for staff, for mask uses. It talks about what to do with staff, how to handle patients, how to handle if you're going in an observation / isolation room. And it also tells you what to do if you have patients who are at high risk and probably should not wear a mask. But make sure, especially if you live in a state where masks are required, 9 times out of 10, that facility is practicing universal source control. Please check the CDC's website. There's a wealth of information on it. Literally, I took the flyers off the website and did training with my staff on it. And so that would be sufficient for you to include in your infection control curriculum. But using language like that when you're on the phone or sending an email to a nursing home administrator makes them feel more comfortable about you being prepared to really come into clinical and being able to manage COVID-19 without having any issues.
Nice. Someone asked this question, I forgot to ask it. Are students actually allowed in the building during surveys?
It depends on that facility's policy. So if I've had good schools before where it was no harm in them staying, so I checked with the surveyors and they said if I was fine with it, then it was fine for them to remain. Some schools take the liberty to just leave. It is ultimately up to the facility.
Okay.
And it's a good rule of thumb. When I owned a school, I would let my students stay because it's good for them to get that experience of working through survey. A lot of times when survey comes in, especially on the state level, everybody's scared as you turn the light on, everybody gone. It's like, what happened? With the sort of whole hall going at the same time, everybody hiding out in the same room, and here's the surveyor down the hall in the room with the call light on, counting for 20 seconds. It took you too long to answer because they're not used to dealing with surveys. So I say, if your administrator feels comfortable, you know your students, if you feel comfortable, and if the surveyors are saying they are fine with it, it's up to the discretion of the nursing home, then I mean, it's good to get them that exposure. However, I'm gonna be honest with you, as a instructor and as a nursing home administrator, I also knew who did not need to be in my building for survey. So if you know you have some students that are just not strong or just not ready, it may be in your best interest for them just to go home and make up that day another day. This is additional information from the CDC on how to handle the face mask. All the do's and don'ts, infamous for hanging it on the elbow. Again, these are the things that I saw this with a school and I just called the instructor in and I was like, I just have too much to lose and I'm gonna need y'all, they had to go. So these are the things, if you teach them this on the front end, again, and incorporate all of this into your bargaining tool with your nursing home administrators. My students are trained on how to handle their face mask. Those are the things that they're looking to hear. Same thing with the respirator. These are good tools to include in your curriculum prior to them getting to clinical. These are the exceptions for mask usage. So in many of the facilities, they also do require the patients or the residents to wear masks. However, if you have patients that have conditions that cause trouble breathing, they're unconscious, incapacitated, or they are unable to remove the mask on cue without assistance, meaning if I tell you, Mr. Brown, take your mask off, if he's not cognitively intact to take the mask off, he's not required to wear a mask. And also if they have trach or any kind of exhalation valves or vents, of course, they would not wear them. But these are things that your students do need to be aware of so that if by chance they come in contact with a surveyor, if they're on the premises, they will ask them, why does this person not have a mask on? They need to be able to speak to, oh, he has a diagnosis of COPD, he does not have to wear a mask, or he has dementia, he's not able to remove the mask on command, so he does not have to wear one. Those are the things that they will ask to try to trip the staff up to see if they're aware. And again, your students can cause deficiencies while they're there, so making sure that they're aware of this is key. Cannot stress hand washing enough. I did see a facility get a tag on the staff did not know that they needed to use sanitizer for the same 20 seconds that they are supposed to wash their hand for at minimum. So we tell them to still sing the happy birthday song. It is usually about 20 seconds. However, now the World Health Organization is leaning more towards 30, 40 seconds and sometimes up to a minute. So if they are on an observation or isolation unit, let them go ahead on and wash their hands for a minute if possible. But make sure that they understand with that hand sanitizer, they can come out of the room and hit it one time and 1, 2 and think they're done deficiency. It needs to be for at least 20 seconds. So these are things, again, including this into your infection prevention and control curriculum. Make sure that they understand social distancing. That does not start in the clinical setting. You need to be practicing that in the classroom setting, even right now. So they need to be 6 feet apart in their skills labs whenever practical, at least 6 feet apart. Make sure that they understand in the clinical setting, resident compliance is very important. So while we can't force the residents to stay 6 feet apart, my building got a deficiency because the residents were combative. The residents kept on saying, no, I'm not gonna do it. So it got to a point where the staff just stopped bothering one particular resident. Well, the surveyor saw the staff member walk past a group of residents who we had documented in care plan that they're combative, they refused, but the staff still did not encourage them to be compliant every single time they saw them, and I got a deficiency.
Mm.
So make sure that your students understand, well, no, I can't pick you up and move you and make you. I can still say every time I see you, Mr. Brown, would you like me to help you to move your wheelchair? Or can I help you to move your wheelchair to separate your, at least giving those pleasant reminders so that we can try to reinforce that this is still something that's required. Your students have to operate like staff.
Quick question.
Mhm.
Tracina, hey Tracina. She said, how do we learn the ins and outs of the surveyors as clinical instructors? Is there like a place where that information resides?
CMS, all their tools, all their survey tools are actual public knowledge, so you can Google the survey, the pathways. The ones for the nurse aid programs are a little more difficult to find, but you can continue, you can keep Google searching, and I'll go through some of my old archives, Victoria, and send it to you, and probably that's something you can forward to them, so that they can be knowledgeable. But everything that the surveyors check for, it's all common knowledge. It's a check sheet, and it tells them, if you see this, then dig and go here. If you don't see that, then continue on your path. So if you train your students to keep them on the straight and narrow, they won't start digging. And that's a good thing. I'm glad she asked that question. That information is definitely readily accessible. It's just most people will give up on the search with trying to find it, but it is accessible.
Okay. So I'll get that, guys, and I'll post it on our Facebook page for you.
All right, these are some examples just to familiarize yourself and then the students of some facility measures you'll see. Again, every state is different, but this is based on my experience here in Louisiana. We are still doing restricted visitation, so only essential employees and essential visitors. We consider essential visitors here in Louisiana like hospice, lab, x-ray, and your providers. So we are scheduling visits for families and caregivers, but there's only a certain amount, it's a certain percentage based on the census per week that they allow in the buildings. If they do have an uptick in cases, visitation is shut down again. So that has the potential to affect your ability to do clinical training. But again, having all those conversations up front, showing how you are so prepared for this, will at least hopefully give you a chance with still having your clinical. Of course, there's screening for everybody who enters the facility. That includes your students, making sure that they know they're gonna need to do hand hygiene when they first go in the building. They usually have hand sanitizing stations there. And during the triage screening, make sure your students understand if they have even the slightest symptom, they need to go home. This is a very frail population. So what you think is allergies may not be allergies. So the slightest symptom, they need to go home. I have seen this literally start off with one staff member sneezing and, oh, this is dry eyes and allergies. And she took out about 40 people with her within the week. So you have to be very, very careful. And then with the comorbidities, these people cannot shake back all the time. And not everybody's been vaccinated. Not everybody's gotten a second round. So there still is the chance for that uptick in cases again. Find out what the state is recommending, or look at the CDC's recommendation for the return to work algorithm. They had decreased it to the 10 days since the onset of symptoms, but now it looks like they're going back towards the 14 days since the onset of symptoms. You need to have guidance readily available. The same thing they use for return to work is what you can use for return to school. So from the onset of symptoms, at least 14 days before they return back into your population, your classroom setting, definitely clinical, because again, these patients are already compromised. If you don't have something in writing, I do have an example at the end of this presentation. It was adopted from my state's health department, but most of these resources and tools that you need are there. You just need to follow up with your state health department. Again, please check the CDC website, familiarize yourself with source control. Do understand that the nursing home has limited group activities that also affects your clinical, so they're not going to be sitting together having lunch all together. If you are assigning two to a hallway to work together, you still will limit the amount of things that they do where they're in close proximity, meaning within 6 feet of each other. Residents are usually encouraged to remain in their rooms unless it's medically necessary, which makes them a little more difficult to deal with. So make sure that your students are aware of that. Again, the need to practice social distancing. We have still not resumed group dining here in my state, which means there's in-room meal service. Make sure that your students are familiar with reading a meal ticket, or they actually know what the term is, meal ticket, tray ticket, because everything is leaving the dining room and they're reading the ticket and making sure they're serving the right person. Also, if that person is truly on isolation, meaning they have truly tested positive, or if they are in observation because their status is unknown, make sure your students know that we need to serve them with the isolation setup, meaning all of their stuff is going to be disposable. Make sure that you familiarize yourself with how frequently your state is testing nursing home residents, because however frequently they test in the residents, that means that's how frequently they are testing the staff. Make sure that any equipment that your students come in contact with, they need to take the liberty of frequently disinfecting them. I'm sure that facilities housekeeping staff has been trained on the frequent disinfection of what they call the high touch areas, but your students also need to know that, and it's no sharing of equipment when all possible, but definitely making sure that they're disinfecting in between. Most of these facilities now are doing the frequent monitoring of vital signs. So whereas in long-term care before, it was usually once a day, now you're seeing 2 and 3 times a day, they're actually going back to doing vital signs. Residents who have identified symptoms are being isolated. So I don't want to hear on the next day, oh, I remember Mr. Brown sneezing. Well, that is the beginning of a symptom and you didn't say anything. So here he has been all over the facility. As soon as they notice something, they need to notify their instructor, and they need to also notify the nurse, because we need to isolate that person until they're tested. And the same as those with unknown exposure. So while they have not updated the school's surveys yet, either if your state does initial surveys for licensure for your school, or if like in my state, it's annual surveys, while this guidance has not been updated yet, I can assure you it is coming. So you might as well start your paper trail now to show that you incorporated the appropriate changes early on. So make sure your infection prevention and control has COVID-19 training in it. Again, you don't have to do anything fancy. This is my forte, this is what I do, but you don't have to have a PowerPoint. You can go on the CDC website and pull their flyers, and therein is your training. Just have proof that you went over it with your students. Again, make sure you have a policy on testing, a policy on returning to school. Do you require a test for them to come back, or is it symptom-based, meaning 14 or 10 days from the onset of symptoms? Make sure you have a sample of a triage form. You actually have the thermometer, and you have the temperature log showing that they were doing this daily. Do not just rely on those facility tools. When you get to clinical, you need to be incorporating something even now in the classroom setting. Another great resource is called a PPE burn calculator. This allows you to foreshadow how much PPE you would use based on a census of the nursing home. And then it also helps you to foreshadow how much you may need to purchase for your students based on the size of your class. You can Google and download PPE calculators for free. But I assure you, when they came into my COVID focus survey in a nursing home, that was the first thing they asked me for, was the initial forms for survey. And then they wanted a copy of my PPE burn rate. You need to get one, and you need to start keeping up with how much PPE you're going through for a class in a clinical setting, so you can have proof that this is something that's being supplied to your students. They're not difficult. It's literally, you put in how many students you have, how much PPE you started off with, and how much you have now after clinical, and it gives you your burn rate. This is information that they won't tell you until they're ready to tag your school, because you're not ready. Consider how you will manage contact tracing after exposure. You can't rely on the nursing home to contact your students and let them know there was an outbreak on the 200 hall. How will you handle that and then still remain HIPAA compliant? Make sure your classrooms and labs are capable of practicing social distancing. Last but not least, remain in close contact with your state health department for updates. They know me by name when I call. Oh, Ms. White, it's on the website, right? But I just had a question because I want to make sure I'm interpreting it the appropriate way, because a lot of times the way things are written, and then when the surveyors come out, is my interpretation isn't the same as the surveyor. So even though it may not make sense to you, you want to understand it and apply it the way the surveyors understand it and are going to apply it. And last but not least, remember, you are training tomorrow's workforce, so we cannot cut corners with this. This is an example of a return to work criteria. It is literally really cut and dry. This is based on Louisiana Department of Health. You should have something similar for your students, return to school criteria. Should they have suspected or known COVID-19, you should have something in writing saying when they come back, how long they have to stay out, whether or not they need a test, or if we taking your word from the onset of symptoms. It doesn't have to look like this, but it's just helpful to have a quick reference so that you know, and your instructors know, even your students know, okay, my symptoms started today, I need to be out until this day or be tested negative to come back. We do also have sample clinical request letters. I will send this copy to Victoria. I know anybody that I've been working with, I've been posting it for you all as well. But again, just pulling on the fact that you are prepared to function in a clinical setting. Your students understand the infection prevention control protocols and policies related to COVID-19. And I think stressing that you have incorporated everything into your curriculum, that should increase the likelihood of you getting clinicals. Again, CDC and your health department, I can't